Today we'll be discussing with you our innovation in maternal health that we've put together here in Philadelphia called It Takes a Village, Reducing Maternal Mortality in Philadelphia Through Coordinated Action. I am Asta Mehta. I'm joined with my colleagues Samantha Schuster and Simone Sneed at the Philadelphia Department of Public Health. Before we begin, we do have one major thing to disclose. This program has been supported by funding from Merck through Merck for Mothers. The objectives of the presentation today are to provide for you an overview of the maternal mortality problem in Philadelphia and describe the components of how we've built community action, and then discuss current activities that are ongoing. So a brief overview of the data in Philadelphia around maternal mortality. We've had an active maternal mortality review team since 2010, and we review all pregnancy-associated mortality, that is a death that occurs to a woman during pregnancy or up to a year postpartum. Our leading causes of pregnancy-associated mortality in Philadelphia include pregnancy-related deaths. So these are deaths that are classified as directly related to pregnancy itself. And then the next big piece is drug-related deaths. We see an overall pretty large correlation with mental and behavioral health issues, where 45% of our maternal deaths have been due to have had a history of mental health disorder, and 58% have a history of substance use disorder. What's notable about our maternal mortality is that 25% had no prenatal care, and this is about 4 times higher than the general population in Philadelphia. Another important theme that is sort of run across all of our reviews and case reviews has been around social determinants of health, and that they play a major role in each of the cases. Our pregnancy-related death rate is about 20 of 100,000 live births. This is slightly higher than the national average of 18.6 for 100,000 live births. Cardiovascular deaths are about 46% of all pregnancy-related deaths, which is also similar to national numbers. And similar, again, to nationally is that there are significant racial disparities in pregnancy-related deaths, in which African-American women are about 4 times more likely to die than white women. The timing is also notable, where 77% of the deaths are occurring in the postpartum period, and about a quarter of them are actually over 6 weeks postpartum in what we consider the traditional postpartum period. Drug-related deaths have increased significantly in Philadelphia in the last few years, whereas prior they accounted for about 25% of the pregnancy-associated deaths, and now they account for about 40% of all deaths. The timing is also notable, where 74% are occurring in the postpartum period. But what's really important is that 66% are actually occurring after the 6-week postpartum period. Racial disparities are still also exist in this population, where in Philadelphia in general, white women are about 2.5 times more likely to die than African American women. However, in the pregnant population and the postpartum population, African American women are equally likely to die of drug-related deaths. And so the disparity is still there within the drug-related death population. In the past, our case review team has identified systemic shortfalls and gap in community resources, and the goal was really that individual stakeholders that were part of the review or that were reading our review reports would take up some of these projects and implement them, for the population. However, because of that process, we were really not able to fully scale up all of our interventions, and people were still kind of working in silos. And as we've seen in our data in Philadelphia, maternal mortality is a pretty complex problem that actually works across many sectors. And so it's really important to coordinate these types of projects and to really attack the problem from a 360 standpoint. And that's why we felt the necessity to create a action team. And this is really a team that it serves as the action arm of our Maternal Mortality Review Committee. And the goal is for really that it works across sectors and really brings people from different areas together so that we can break down silos and get things accomplished to really affect the whole population. As far as we know, this is the first of its kind in the country in regards to putting a formal action team together, specifically in a city. And so we're focused mainly on our 3 areas that we've identified through our data. The first is racial disparities. The second is substance use disorder, as our drug-related deaths I've mentioned have gone up significantly. And the third is cardiovascular complications, as those are the most common cause of our pregnancy-related deaths.
The OVA intentionally works across sectors to carry out those recommendations made from the Philadelphia Maternal Mortality Review Committee. And ultimately, we examine and fill gaps in stakeholder representation to ensure that the team has a complete multidisciplinary and community representation. It works closely with additional organizations and institutions representing various disciplines within the Philadelphia maternal child health community. And some of those organizations and stakeholders that we have at the table are government agencies, community members, healthcare system professionals, insurance providers, community-based programs, policy advocates, and social determinants of health professionals. And we have 4 main goals for the OVA, and those goals are to implement and support innovative citywide interventions that specifically address the leading contributors to maternal mortality in Philadelphia, building upon existing collaboratives focused on target areas. So we don't want to reinvent the wheel. We really want to strengthen the programs and projects that already exist, as well as infusing funding into those pilot projects and working across sectors to integrate community voices and solutions into policies and programs.
In order to ensure that we embed community voice in all of our work, we do the following things. We have hired a community specialist that provides feedback on the development and infrastructure of the OVA. We ensure that we have community members as part of our steering committee. We will also have community members be part of our work groups. Each work group will have one of their co-chairs be a community member. We ensure that community members are not just there to tick a box, but really are there to have influence as leaders. Community members are compensated for their time being part of the meetings and any work they're doing in preparation. Before our steering committee launched, the community was interviewed as part of the development of the OVA. This information was used to plan all aspects of our governance. Finally, we have written an equity statement in our governance that lays out exactly what we as a coalition value about community feedback. We also create an equity plan as a guide with recommendations for implementing equitable practices within the collaborative. This is based upon a 55-question equity audit tool developed by our consultants. This tool was developed to measure progress on activities related to equity in a collaborative cross-sector setting. Each practice developed is under one of the following categories: framework, which is a foundation and language that the initiative is based on; leadership and structure, the composition of the initiative's decision-making and governance; inclusive meeting norms, the guidelines and practices that support effective and inclusive meeting space; community logistics, the practices that eliminate physical barriers of engagement; data empowerment, the use, collection, and distribution of data based on the initiative's vision; advocacy for equity, the practice of championing anti-oppressive strategies; and communications, the selection and use of conveying the initiative's message both internally and externally. We use an equity practice worksheet to track our actions as steps the initiative is currently undertaking, and also as recommendations, which are suggestions and actions that should be taken to implement the practice or policy.
We're defining success of our innovation by developing activities that are based on the current review process of the Maternal Mortality Review Committee, and those ensure all projects are data informed. Themes from review will go through a secondary committee to create actionable steps. We're also including community-based data, so stories from moms and birthing people, as well as community conversation and what that looks like. We're also ensuring that all activities are reviewed by lived experience experts and stakeholders in each sector. And we also have a community specialist on our team to assist us with that portion of success building. We develop metrics for individual projects, as well as we develop a process for evaluating those results in relation to Philadelphia's maternal morbidity and mortality rates. Our current activities, we have a lot of activities going on with the OVA, and we're really excited to strengthen them over time. So we're strengthening the maternal mortality surveillance process, increasing access to family planning for women with substance use disorder, creating and disseminating implicit bias training geared towards clinical maternal health providers, infusing funding into community doula programs to increase contact in the postpartum period, initiating a text-based postpartum hypertension monitoring program, Heart Safe Motherhood, at all delivery hospitals in Philadelphia. We're establishing case management for pregnant women with substance use disorder who are released from prison, as well as educating maternal health partners on the impact of unmet legal needs on maternal health.
I'd like to conclude by thanking everybody for tuning in. I just want to reiterate that this is a problem that is everyone's problem, and so if we really want to improve maternal health and decrease maternal morbidity and mortality, it's imperative that we all start working together and across silos, as this is as we've mentioned already, a very complex issue, and that is exactly what we're hoping to contribute to the larger community and use our team as an example to see what we can do together. We've come a long way in Philadelphia. We have very dedicated individual stakeholders that have moved projects forward, but we still have a long way to go, and it's really important, and I'd like to emphasize that enough. I can't emphasize that enough, that it's really important that we do it together. We're so happy to be a part of this session, and if there's any questions that you may have or would like more information about our project here in Philadelphia, please feel free to email us. Simone Sneed is our project coordinator, and and that is her email right there. So thank you, everybody, and thanks.